welcome to today's case study carrying on our CNS theme. Today's case study revolves around Parkinson's disease and dopaminergics. Let's start. Now, the wife of one of your regular patients, 75-year-old Mr. PD, enters the pharmacy. She tells you Mr. PD has been feeling a bit sick since upping the dose of his Parkinson's disease medication. She also noticed he has been getting a persistent cough and quite short of breath recently. Thus, she went to see the GP to get something to help with his problems. The GP said he would give something for the sickness and that the shortness of breath is probably asthma. Dr. Locum said for Mr. PD to come back in a week's time after using the blue puffer he prescribed. She hands you the following prescription. Identify the 2 drug therapy problems present. Now, Parkinson's disease is a neurodegenerative disorder of the CNS that was initially famous for affecting what we know as the motor system. So this affects movement and so forth. Now, how does, all this intertwine with Parkinson's disease? Now, normally, there's dopaminergic neurons and dopaminergic pathways that affect the motor cortex. And there's 4 main dopaminergic pathways in the brain. And the one we're going to zoom in on is known as the nigrostriatal pathway. And this is the one that mainly affects movement. Now, normally dopaminergic neurons in the substantia nigra, they basically are found as part of the basal ganglia and input dopamine to what we call the striatum. Now, this isn't anatomically correct, and I'm just drawing this in a way so it's more visually engaging and easier to look at. Now, how does this, affect dopamine? The amount of dopamine that, how does this affect movement? This amount of dopamine that's being inputted to the striatum. Well, now we have to look at 2 other pathways that are involved in motor function. You've got the indirect and the direct pathway. Now, before that, we have to look at the thalamus. Now, the thalamus is known as the relay center of the brain. Now, the way I like to think of the thalamus is, imagine you've got an airport strip, and then you've got planes, landing and going, and then the thalamus is the control tower. So it's telling all the planes, you land here, this one's free, go over here, go over here, go over here. So it's relaying signals to the appropriate area of the brain. So it's nicknamed the relay center. Now, you've got the internal globulus pallidus, and this basically sends signals to the thalamus to either increase or decrease signals, depending on, so it will increase and decrease signals to what we call the motor cortex. So the GPI will basically tell the thalamus to increase or decrease activity to the motor cortex, and the motor cortex will send signals to our muscles to, either increase or decrease activity, so the signaling there. Now, the direct pathway, we zoom in on the direct pathway. What the direct pathway normally does is, when the substantia nigra sends dopamine to the striatum, it basically sort of increases activity to the thalamus to tell it to increase signaling to the motor cortex and increase activity to the muscles. So normally the direct pathway will increase the thalamic activity to increase signaling to the motor cortex, to increase signaling to our muscles. So this normally happens to say when you're going from walking to running, you need that, increase in movement. So an increase in dopamine in the striatal area will basically tell the thalamus, okay, sort of you can increase activity to the motor cortex and to the muscles. So obviously we can tell that a decrease in dopamine thus is going to decrease this amplification to the thalamus, which is going to decrease signaling to the motor cortex and thus to the muscles. So you're going to get slowing of movement. And that may occur, as you can see, as motor symptoms in Parkinson's. Now next we have what's called the indirect pathway. And the indirect pathway, it acts to decrease thalamic activity, and it has inhibitory action. This then basically decreases signaling to the motor cortex to reduce signaling to, muscles to move. Now, you have to remember that the substantia nigra activity of dopamine fine-tunes the dopamine in the striatum to ensure that we move at a decent pace and ensure we don't slow down movement too much. But, it's basically ensuring that the thalamus isn't inhibited to too much of an extent. Now, this is important because, say, for example, you're running and you want to slow down because you're coming up to, some pavement or someone's come in front of you. Now, a lack of dopamine means we cannot slow. So say, for instance, we have a lack of dopamine here in the striatal area because it's not being inputted from dopaminergic neurons from the substantia nigra into the striatal area. It means we can't slow that inhibitory tract on the thalamus, and so you're going to have an excessive inhibition caused by the thalamus. So you're going to have excessive inhibition of the motor cortex and excessive inhibition of signaling to the muscles, and so you're going to slow down movement too much. So that's going to be quite bad. So you're going to get a lot more motor symptoms. But overall, if we summarize, this means a lack of dopamine in the nigrostriatal area is going to result in the substantia nigra not being able to stimulate the direct pathway for more movement, and it gives excessive inhibition of the indirect pathway. And so overall, this is going to mean that you're going to have excessive slowing down and loss of movement, and so you're going to get symptoms such as bradykinesia, so slowing down the movement, and all those motor symptoms that you associate with Parkinson's disease. Now, one way to combat this is to try and thus increase dopamine in the nigrostriatal pathway. And one way to do that is to give a drug that activates the postsynaptic dopamine receptors, so like D2 and D3. And an example of a drug that does that is a dopamine agonist. The one being taken by this patient is bromocriptine. So that will help, reverse the action that's occurring. So this is going to give greater relief on the movements and alleviate some of the symptoms. Now, bromocriptine's an ergot derivative. Now, something else that we need to talk about is the effect that dopamine is actually going to have on communication between the chemoreceptor trigger zone and the vomiting center found in the medulla, which is actually part of the brainstem. And what you have to find is by increasing communication between these two areas, it can cause patients to obviously feel sick. So they may get nauseous and they may even vomit. And so this is probably what's being experienced by Mr. PD since upping the dose, because you're increasing dopamine in this area. Because remember, the drug's going being systemically given. So one way we can counter this is by blocking the D2 receptors by giving a drug that acts as a D2 antagonist, because obviously the reduction in dopamine is hopefully going to alleviate these symptoms. And a drug with those properties is metoclopramide. Now, as well as that, it also acts to speed up gastric emptying. So if you empty the gastric contents quicker, then hopefully you won't feel as sick. So speed up gastric emptying. And it has partial effect to that because it helps, block serotonergic 5-HT3 receptors and to some extent agonize 5-HT4 receptors as well. And so sometimes it's known as a prokinetic agent. Now, however, remember what we talked about earlier, where we said a decrease in dopamine is actually going to cause some of the symptoms if we decrease the dopamine in the Niagara striatal pathway. So one thing that we are going to realize, if we give a D2 antagonist, we're going to further decrease dopamine, and that's going to exacerbate patient's Parkinson's disease, in this case Mr. PD's Parkinson's disease symptoms, because metoclopramide readily crosses the blood-brain barrier. Now, this is something that should be flagged up with the prescriber, and it may actually be something that we have to be aware of. And so one way that we can do to combat this is to give a drug with a similar mechanism of action, but it doesn't as readily cross the blood-brain barrier, and it's also thus comes under the class of prokinetic agent, and that's domperidone. So it will still alleviate the sickness, but as it doesn't readily cross the blood-brain barrier, you may not exacerbate Mr. PD symptoms. Now, obviously, there's other things that have to be factored in. So, for instance, there's a risk it can, prolong QT interval and so forth. And obviously, we have to take a case-by-case basis. But this is one drug that may be given as an alternative. Now, we have identified our first drug therapy problem. Let's move on to our second drug therapy problem. If we go back to the question, we can actually see that Mr. PD, the wife, has been complaining that he's been getting persistent coughing and short of breath quite recently. Now, dopamine agonists, like bromocriptine, there's certain subtypes which are known as ergot derivatives like bromocriptine. Now, ergot derivatives are those that are derived from, ergotamine star, and they can cause, vasoconstriction, and they were used previously for migraine. They can cause other side effects. But one thing that was noticed in particular is they can cause fibrotic reactions. And these can include causing pulmonary and pleural fibrosis. So, scarring and build-up of connective lung tissue. This may actually explain some of the symptoms, like the persistent cough and shortness of breath being experienced by Mr. PD, and it should be flagged up to the prescriber just to double check that it's definitely not this that's occurred, because if this is the cause, the side effects are often reversible if it's stopped quickly. One option may be to potentially give the patient one that's non-ergot derivative, the same class of dopamine agonists. An example of that may be ropinirole, but there's others, and these are just a few options, and again, the benefits and risks should be weighed up appropriately. With both drug therapy problems identified, let's move on to the patient query portion. Now, the question reads, whilst sorting out Mr. PD's drug therapy problems, Mrs. PD says she also noticed that Mr. PD has been going to the casino very frequently. Mrs. PD tells you this is very out of the ordinary for him, since Mr. PD has never gambled in his life. She asks for your advice. Now, this excessive gambling being exhibited by Mr. PD may in fact be a side effect of the dopaminergic being taken by Mr. PD, in this case a dopamine agonist. This side effect is collectively known as an impulse control disorder. And it can be relatively common depending. Dopamine agonists are quite common at causing it compared to other dopaminergics, and there's different postulated mechanisms for this. Some believe that you may actually get a reduced sensitivity in the reward system as seen in drug addiction, pathological gambling in non-Parkinson's disease patients. Now, this reward pathway is a dopaminergic pathway known as the Mezzo-Limbic pathway. Now here, an increase in dopamine, so this pathway, it can cause pleasure and reward when there's an increase or overabundance of dopamine here. And so what they believe is that a constant increase in dopamine here by dopaminergic drugs may eventually give a blunted neuronal response to rewards like unexpected financial gains and so forth. And so you get this pathological gambling and response. And so this may be one mechanism. Also, it's believed that they may actually disrupt appropriate negative feedback mechanisms from negative outcomes seen in reinforcement learning. Like with a child, you get that, that consequential learning, but this is something that you'd have to think about as well as a postulated mechanism. In particular, they say the ventral tegmental area over time can cause a creation of this compulsive drive to keep trying to reach reward as a result, giving rise to hypersexuality or gambling impulses as being exhibited by Mr. PD. Disrupt negative feedback. Negative reinforcement learning. Now, it's best to flag these up with the prescriber and to actually refer the patient to have their therapy plan reassessed and flag up these concerns. Now that wraps up today's case study. If you found today's video helpful, please give it a thumbs up and don't forget to subscribe to the channel, making sure you hit the bell icon of course, to keep updated on new videos.